Welcome to today's ovarian cancer congressional briefing. We will give it about 30 seconds as people dial in. My name is Kenita Seeley and I'm Policy Counsel for the Black Women's Health Imperative. I have the honor of serving as today's moderator. Today, you will hear from members of Congress, patients, a physician, advocates, and industry leadership. As you listen, you are welcome to post questions and comments, and we will refer to them during the Q&A at the end of the program. We are also recording this briefing and plan to send you the link afterwards. First, we like to start with patients because that is what this is all about. Please join me watching a short video of real patients' stories.
In case you don't remember me, I'm your patient.
I'm your patient.
I'm your patient.
I came to you numerous times over the course of 5 months looking to get answers.
I was having pain in my abdomen and feeling bloated.
Swelling, weight gain, pain and pressure in my abdomen.
And a feeling that something was just not right.
I filled out the form stating my mother had died of ovarian cancer.
That my mother died of breast cancer.
That I'm an Ashkenazi Jew.
Did you read my chart?
Did you know my history? I'd been back twice in a month with pelvic discomfort and a frequent urge to urinate.
You dismissed my concerns about ovarian cancer and stipulated that the 1CA125 test given 10 years prior was all that was needed.
You sent me on my way with a prescription for anti-anxiety meds.
I was made to believe that this was all in my head.
You were wrong.
You were wrong.
You were wrong.
While you failed to investigate on all of these occasions, the clock was ticking, and my very precious window for early detection had closed.
I was blindsided by the diagnosis of stage 3C ovarian cancer.
I've undergone multiple surgeries and chemotherapy.
I have endured 8 long years of brutal surgeries and procedures, and 8 separate lines of cancer treatments.
If you had referred me for genetic testing, I would have discovered pre-cancer that I carried the BRCA1 mutation.
I would have learned that I not only have an 85% lifetime risk of breast cancer, but also a 40 to 60% lifetime risk of ovarian cancer.
Had I known, I would have taken the necessary precautions.
You completely robbed me of this preventative choice. Whenever I spend time with my children, I'm left to wonder how long I'll be able to participate in their lives.
The chances of me being able to celebrate their high school graduations are almost 0.
Now do you think about prevention and early detection of ovarian cancer when women put their lives in your hands?
Do you think about us?
Do you think about me?
Do you remember me?
Thank you for that very moving collection of true women's stories. If we could please go back to the agenda slide for those who may have missed it. This is a lineup of our excellent speakers that we'll be having this afternoon. Opening comments by Congresswoman Rosa DeLauro and Congresswoman Madeline Dean. A patient's perspective by Dr. Diane Powers, and a clinician's perspective by Elena Ratner, and the impact of ovarian cancer on Black women given by Linda Golair-Blunt, and the policy recommendations by Chad Ramsey, and a call to action by Valerie Palmieri, and final takeaways by Diane Powers, and then we'll have a final Q&A. So next I would like to introduce Congresswoman Rosa DeLauro. Congresswoman DeLauro is the chair of the House Appropriations Committee and the subcommittee that funds all health programs and services. While she represents Connecticut, stretching from Long Island Sound to New Haven, she represents all women and all who are vulnerable and underserved in her powerful seat in Congress. She's a champion for addressing health gaps, especially ovarian cancer. I am pleased to present Congresswoman DeLauro.
Hello, this is Congresswoman Rosa DeLauro, representing Connecticut's 3rd Congressional District. I want to thank Dr. Christina Jenkins for those kind words and generous introduction. and for welcoming me here at the Ovarian Cancer Awareness Month Congressional Briefing. I would also like to recognize Dr. Elena Ratner, Associate Professor of Obstetrics, Gynecology, and Reproductive Sciences at Yale School of Medicine. CEO of Aspira, Valerie Palmieri. Dr. Diane Powers, psychologist and clinical specialist with Greenwich Hospital Association, Yale, New Haven. And Vanessa Kramer, Policy Director at the Ovarian Cancer Research Alliance. Please also let me welcome my colleague, Congresswoman Madeline Dean. And of course, I want to thank all the researchers, advocates, investors, healthcare providers, and all the members of the National Ovarian Cancer Coalition, Women's Health Innovation Coalition, and the Black Women's Health Imperative for joining us today. You have all been such wonderful partners, and I am so proud to be your ally in your efforts to find new solutions to prevent, detect, and treat ovarian cancer and improve the health of all women across the country. As some of you know, the fight against this disease is personal for me, and I can tell you firsthand that early detection saves lives. I consider myself extremely fortunate that my own ovarian cancer was detected in its earliest stages, purely by chance. Several years ago, I went to the doctor on an unrelated medical visit, and if it had not been so fortunate and not had the excellent doctors that I had, who detected my ovarian cancer in stage 1, I might not be here today. That is why I have long believed that access to preventive services are critical, particularly for women's health. That is why every year I introduce a bipartisan congressional resolution designating September as National Ovarian Cancer Awareness Month. And it is why I have championed the Gynecologic Cancer Education and Awareness Act, also known as Johanna's Law. From the time it was first passed in 2006 to when it was signed into law in 2007, we need to ensure women have the best information possible in order to fight this disease. And that is why, as chair of the Labor HHS Appropriations Subcommittee, I have committed to increasing funding for Johanna's Law year after year, even though it has not yet been reauthorized. Johanna's Law, which has helped save lives by funding a national education and awareness campaign for women that details the symptoms, risk factors, and prevention strategies for gynecological cancers. Fortunately, the reauthorization passed out of the Energy and Commerce Committee earlier this summer. I believe we can get it signed into law to ensure Johanna's Law continues for years and years to come. As a 34-year survivor of ovarian cancer, I am alive today thanks to the grace of God, the care of hardworking medical professions, and the power of biomedical research. And as chair of the Labor, Health, and Human Services and Education Appropriations Subcommittee and chair of the Full House Appropriations Committee, it allows me the opportunity to continue to support and invest in essential research. That is why in the fiscal year 2022 bill, the House passed legislation provides a $49 billion for the NIH, an increase of $6.5 billion above 2021. This includes an increase of $3 billion to establish the Advanced Research Projects Agency for Health, or ARPA-H, to accelerate the pace of scientific breakthroughs for diseases such as ALS, Alzheimer's disease, diabetes, and cancer. The bill also includes an increase of $3.5 billion for existing NIH institutes and centers, which supports an increase of no less than 5% for each institute and center to support a wide range of biomedical and behavioral research. Medical research saved my life and countless others. So that is where you all commit. Remember that Congress is an institution that responds to external pressure. Please continue to stand up and speak out. You will be heard. Thank you all for your passion and your commitment to this cause. And thank you again for welcoming me today.
Now I have the pleasure of introducing another leader in Congress who hails from just outside of Philadelphia, Pennsylvania. Congresswoman Madeline Dean is co-chair of the Congressional Caucus on Women's Issues and has worked hard to address women's health issues in the House. She also has been personally touched by ovarian cancer. Congresswoman Dean.
Hello, and thank you for including me today. My name is Madeline Dean. I'm Congresswoman from Pennsylvania's 4th Congressional District, suburban Philadelphia, and delighted to join you in this awareness of ovarian cancer during Ovarian Cancer Month. I really thank you. I thank particularly the Black Women's Health Imperative. I thank the Aspira Women's Health and the Ovarian Cancer Research Alliance. I also do want to say a special shout out to Dr. Diane Powers and my friend, mentor, colleague, Representative Rosa DeLauro. My name is Madeline Dean, and I care desperately about women's health and to make sure that women's health care is provided the top care that is possible. 1 in 2 women is diagnosed with ovarian cancer and will die from the disease. It's frequently misdiagnosed or never diagnosed. It is not included as part of an annual gynecological exam in many cases, like other cancers are. And we see radical disparities in diagnoses and treatment. And I have to tell you, I have a personal connection to the devastation of ovarian cancer. My own mother in 1993 came to me and complained that she had a terrible stomach pain, thought maybe she had gotten an ulcer. And within a matter of weeks, we learned her diagnosis was ovarian cancer, learned it in January of 1994, and February 16th of 1994, she died. We were devastated. My mother didn't have a chance. She was an extraordinary woman, and I just want to say that, Mary Dean, an extraordinary woman. So what can we do? What can women all around the world, what can Congress do about this? We can support more robust education about the topic. We can advocate for research, investment to learn more about this deadly disease, too often too late caught. We can pass healthcare legislation that includes insurance coverage for the treatment of ovarian cancer for what the patients actually need. And we can speak out about the health disparities and inequities that we see across the board. As co-chair of the Congressional Bipartisan Women's Caucus, I prioritize issues that affect women and their families every single day. Every woman, no matter her identity, should have access to full, robust healthcare that she needs. This should not be controversial. This should not be political. This should be an unalienable right. The women bravely fighting for ovarian cancer. We see you. I see you. I hear you. I need to fight for you every single day. We can learn so much from their stories, from your stories, from my own mother's story. And I am grateful. Thank you, Diane Powers, for the work that you have done. Thank you for your bravery and fortitude. It is an extraordinary opportunity. It's a privilege for me to be with you today. Take care.
Thank you for those fantastic remarks from both Congresswoman DeLauro and Dean. We appreciate all you're doing in Congress to address ovarian cancer. Next, we have 5 speakers with a range of expertise and experiences that will move your hearts and minds to action. We want to conclude today's program with action and encourage you to work with us to make a difference for women. First, you will hear from a patient named Dr. Diane Powers. She's a psychologist and a clinical specialist affiliated with Greenwich Hospital Association at Yale, New Haven. She will share her story that is typical of far too many women. She is an amazing beacon of strength and determination with insights that can truly save lives. We will then hear from Dr. Elena Ratner, who is Associate Professor of Obstetrics and Gynecology and Reproductive Sciences and the co-chief of the section of Gynecologic Oncology at the Yale School of Medicine. She will share her perspective on this disease state and what she sees in her practice that must change in order to better serve patients. Next, Linda Golair-Blunt, who is president and CEO of the Black Women's Health Imperative, who spent several years working at NIH as an epidemiologist advancing science, will explain the historic and present racial disparities and inequities that continue to drive the high mortality rates of women of color, the disproportionate impact of ovarian cancer on Black and brown women who are diagnosed too late and die much sooner must change, and she will provide key insights on how to achieve this. We will then hear from Chad Ramsey, who is Vice President for Policy for the Ovarian Cancer Research Alliance. He will share key policy recommendations to improve how we prevent, diagnose, and treat ovarian cancer to save lives. Finally, Valerie Palmieri, CEO of Aspera Women's Health, will share information on the only multi-factor diagnostic for women with pelvic masses to accurately detect cancer during the critical early stages of cancer. While we face significant challenges in reversing the incidence of ovarian cancer and ovarian cancer deaths, you will hear how innovation in diagnostics is providing tremendous life-saving opportunities for change. Then just before I lead our Q&A session, we will go back to where we started, and that is with the patients. Dr. Powers will share the key call to action that we want each and every one of you to take away today. So let's start with Dr. Diane Powers. Diane?
Thank you. Thank you for your time today. It's an honor to address you. You'll probably notice my voice is hoarse, a bit breathy. It's cancer related, but it doesn't hurt for me to speak. Please bear with me. I have a friend here in case my voice is too weak to be heard, but I'm going to do my best. My name is Dr. Diane Powers. I'm a clinical neuropsychologist, chief spokeswoman, patient advocate, wife, mother, and ovarian cancer patient. Your mother, wife, daughter, sister, grandmother, friend, or constituent may have ovarian cancer too. It could even apply to you, at least the female listeners. You just may not know it. And that's because women may have ovarian cancer, but are unaware until it's too late. A devastating but preventable fate. That's exactly what happened to me. And what it means now is that at 54 years of age, my journey through life is near an end. My condition is now terminal. After almost 9 years of fighting and 10 lines of treatment, there are no more options for me. I will soon no longer be here. That's why I've joined this briefing today. This will be one of the final actions of my now ending life's journey, but it's one of the most important actions I've ever undertaken. My situation, unfortunately, is not unique. It's due to the insidious nature of ovarian cancer, the often vague, overlooked symptoms, dismissed by so many women, tragically by their doctors, that thousands of women die needlessly from this devastating disease each year. Like the majority of women with ovarian cancer, mine was diagnosed at a late stage. And like the majority of late-stage diagnoses, this was preventable. Although my competent and well-meaning doctors missed a plethora of symptoms in conjunction with my very significant family history of other hereditary cancers. My journey encompassed myriad misdiagnoses, UTIs, overactive bladder, perimenopause, spinal strain due to stress, diverticulitis, colitis, procedures, medications, consultations with gynecologists, internists, urologists, gastroenterologists, and others. After 10 long months of symptoms and being bounced from specialist to specialist, my unknown pelvic mass was only discovered during an attempted colonoscopy, one that couldn't be performed because the gastroenterologist discovered my lower colon was highly obstructed from above by a cancerous pelvic mass. I woke up from the twilight and was completely blindsided. The 8-hour debulking surgery to rid me of this mass and all other visible disease confirmed that I had stage 3C ovarian cancer that, undetected and untreated, had spread throughout my abdominal cavity. My prognosis was at best 5 years. I'm only still alive today, 3 years plus beyond my prognosis, because of incredible advances in gynecological oncology. However, it's been a grueling 8+ years. Staying alive has required nightmarish surgeries and aggressive treatments, causing physical and emotional strain, financial pain, a lifetime of uncertainty for myself and for my family. Sadly, my story is far from unique. Multiple misses and consequent late-stage diagnoses continue to be the common narrative for women with this malignancy. Faced with these dire detection, diagnosis, and survival facts, coupled with women's 20% probability of developing pelvic masses over their lifetimes, questions arise. First and foremost, is this acceptable? And if not, what can be done to significantly change these outcomes? How can we best improve early detection and diagnosis, as well as survival rates? How can we best identify which pelvic masses are likely to be manifestations of ovarian cancer, and which of these masses must be treated surgically? Aren't we in need of new testing modalities that will enable improved identification of women at risk? The past 4 decades have brought no change in the insufficient and inappropriate standard of care for the testing of pelvic masses, namely the CA-125 test. A bright light needs to shine on the dark, devastating disease that is ovarian cancer. Only a call to immediate action can effect radical systemic change that must happen in order to protect women from the preventable nightmare that is this disease. Thank you.
Thank you, Diane. I'm Elena Ratner. I'm a gynecologic oncologist at Yale. I'm here today and really every day to honor Diane in her message and in her strength. Diane, I am always in awe of you and who you are and what you have done and how much and how hard you are fighting every day so that this story is different for the women, different for your daughter, different for my daughters, different for all of our daughters. You know, all of us here are listening to you and all of us here are committed to your message and to propagating it and doing everything we can so that this narrative is different. And I'm here for all my other patients who are suffering and undergoing chemotherapy. I want to talk to you today about ovarian cancer, about the horrific nature of ovarian cancer, and the fact that we must do better. Women are dying. Women are suffering. Women are suffering, and then women are dying. Children are growing up without mothers. Families are being destroyed. 21,000 women are going to be diagnosed with ovarian cancer, and more than 13,000 of them will die from this disease. And this is very different from other common cancers, such as prostate cancer or breast cancer, where 5-year survival is as high as 97% for prostate cancer, 90% for breast cancer. 5-year relative survival for ovarian cancer is 49%. And as Diane mentioned, this really has not changed over the many decades, and not at the lack of us trying. We are trying so hard, so much research is being done about treatments and surgeries, and yet this number is almost unchanged. The big reason for this is that great majority of ovarian cancers are still diagnosed at a late stage. More than 60% of ovarian cancer is diagnosed at stage 3 and 4, compared to 8% for breast cancer, 13% for prostate cancer. This makes an amazing difference. Women, just like Congresswoman DeLauro mentioned, women who are diagnosed at early stage survive. Women who are diagnosed at late stage suffer from this disease, and then most succumb to it. This mortality is unacceptable. It is unacceptable in all women, and it is particularly unacceptable in women of color. Women of color die from this disease at even more unacceptable rates than Caucasian women. There's so much that we can do for prevention of these cancers. The future of cancers, the future of ovarian cancer, and the present of ovarian cancer is not even early detection. It is certainly not trying to cure it at later stages and putting in all this money into chemotherapies. It is truly prevention. It is awareness. It is advocacy, both on the patient and community side and on the physician and provider side. This is where we need to do better. We need to speak about this. We need to hear about it. We need to all be aware and all join the community to improve this early detection and prevention. We know that so many of these cancers actually have a genetic predisposition. The number we quote is 10 to 15%, but this number is probably higher. So many of these cancers could be prevented if we knew that women have genetic predisposition, and these cancers can actually be prevented in these women. Next slide, please. This is the difference that early detection makes. It is truly a difference between life and death. Women who are diagnosed in stage 1 disease have 93% of cure or 5-year survival, versus as low as 30 to 27% in stage 3 and stage 4, the most common stages that these cancers are diagnosed. And you can see that only 16% of women are actually diagnosed in stage 1, and great majority are diagnosed with advanced disease. Next slide, please. The reason for this is multifactorial. Physical examination is very limited. Physical examination misses a great majority of masses. The testing that we have for this currently, the biomarkers that we have available currently, which are the standard of care, which is C125, is a 40-year-old test without advancement, which we have always known misses a great number of these cancers. We also know that this marker, the C125 marker, is not only inadequate in all women, it is particularly inadequate in women of color. The mortality that I mentioned to you before in minority population is even more profound due to the late diagnosis in this population, even more so than the Caucasian women. Unacceptable on all fronts. And the biopsy that we would need for other cancers to be able to diagnose this cancer is not possible in ovarian cancer, because you cannot biopsy these pelvic masses because you would spread the cancer. What makes this diagnosis so difficult in early stage. Next slide. For generations, we used to talk and we used to say that it is impossible to find ovarian cancer early. We used to say that ovarian cancer is the cancer that whispers, and it's impossible to find these cancers early. But we now know that it is not the case. Ovarian cancer is not whispering, it's that nobody is listening to it. Ovarian cancer clearly has symptoms. Multiple studies have been done, the biggest one by Barbara Goff from Seattle, that showed that even though majority of women had symptoms in late stage, great majority, as high as 87% of them, also had symptoms in stage 1 and stage 2. And these symptoms are vague. The symptoms are pelvic discomfort, urinary symptoms, bowel symptoms, abnormal bloating, not feeling well, gaining weight. And the trouble is that there's not enough advocacy and there's not enough awareness on the patient side to appreciate that those symptoms are not normal. But what's even worse, there's not enough awareness and there's not enough advocacy on the provider side to catch these symptoms early. Diane's story is so true. I see women like that every single day. There's literature that women who are diagnosed with ovarian cancer have had ovarian cancer for as long as 1.5 to 2 years. And many of them have seen multiple providers, as many as 6 providers, before finally being diagnosed. So many of my patients, so many of my women tell me story after story how they knew that something was wrong. They knew that something was not right. And they listened to their bodies and they went to their providers. And yet those providers did not piece the symptoms together to identify those symptoms as those being of early ovarian cancer. And time was spent and diagnosis was missed and the window for early diagnosis was closing. So much of what we as providers need to do is to listen to women. And so much that women have to do is to know their bodies and listen to them and to demand the care they deserve and not to be turned away and not to be told that everything is fine and it's just in their heads. That is what we need to do better on. This is our time. Our time is now as physicians, as providers, to listen to women and to form these partnerships where we and women are together in finding these cancers early, no matter what. Next slide, please. And this reality is even more profound and even more unacceptable for women of color. We have known forever that women of color do worse, and that has to do with many different aspects. It has to do with the kind of cancers they get, unfortunately, are worse cancers, are more aggressive cancers. But it also has to do with even worse lack of early diagnosis and at times suboptimal care. The C125, which is the current standard that is it has, it's 40 years old, we have known for a long time was not adequate in women of color, and particularly in Black women. It misses as high as 67% of ovarian cancer in Black women. And that is why we desperately need more research. We need awareness. We need acknowledgement of this crisis in women, and in particular women of color, for better diagnosis, for better biomarkers, for biomarkers like OVA1 that is more personalized, more specifically for women, not just for any women, but for specific women of different specific ethnicities and races that helps us detect these cancers early. We know that Hispanic women are diagnosed at earlier age than non-Hispanic women. We know that Asian Pacific Islanders have a higher age-adjusted incidence rates than white women or Black women, and they very frequently have cancers of worse aggressive nature, such as clear cell carcinoma. But so little literature exists in this population. So little of these populations have been studied in order to provide personalized care. This is our call to action. The time is now. The time is to acknowledge that women with ovarian cancer have not been treated right. We have not done right by our women. We have to do better. We have to do everything it takes between awareness, but also research and early detection and biomarkers, anything we can do to improve early detection, because detecting these cancers early will literally save lives. So Diane, yet again, I am here for you. I think all of us are here for you. Your message is so clear. And I think of you, Diane, every day I see my patients, I never forget your message. I never forget your strength, your message, why you're here and how much you have done and how much you're going to continue to do. Thank you.
And thank you, Elena and Diane. Once again, your strength is so inspiring, and your story maddening for all of us to hear. Because, as you said, this has happened to far too many women, and we will continue to hear this story. So on the next slide, a little bit about the Black Women's Health Imperative. We are the nation's only national nonprofit organization focused on the physical, emotional, and financial wellness of Black women and on achieving health equity for them. And that means Social justice needs to happen as well. Our areas of focus are chronic disease prevention and risk reduction, maternal health, reproductive justice, HIV prevention, and we have a program focused on young women in college. And all of this is undergirded by our policy work, both at the state and federal level. And in the last few years, what I've brought to the Black Women's Health Imperative is research. And so we're very much focused now on increasing the numbers of Black women who participate in clinical research, but also improving the number of researchers of color and increasing funding on those diseases that disproportionately impact Black women. So on the next slide, there's mixed news. According to the American Cancer Society, in the last 35 years or so, the overall ovarian cancer incidence rate has declined somewhat. Overall mortality has declined somewhat. But as you look at the graph, you see there's a mix depending on what race or ethnicity you're looking at. What's important to look at is the survival rate. So overall, the survival rate for ovarian cancer for white women increased from 33 to 48%. That's great. But for Black women, it decreased from 44 to 35%. As you heard from Elena, for the Hispanic population, for the API population also, outcomes are not as good. And for Black women with ovarian cancer, the all-cause mortality rates are 30% higher than for white women. And as you've heard, if we can catch ovarian cancer early, stage 1, then it doesn't matter what the woman's race or ethnicity is, she'll have better than a 90% chance of long-term survival. But Black women are less likely to undergo, first of all, the initial suspicion of ovarian cancer. That journey from symptom to diagnosis for Black women might be 2 to 3 years, not 1.5 years. They're less likely to undergo initial surgical intervention. They're less likely to live near an academic medical center, so less likely to have access to high quality care. And they're actually less likely, according to a number of studies, to receive care in accordance with NCCN and ACOG guidelines. So on the next slide, there's a little bit about what we know. There's biology and genetics, cancer that affect cancer outcomes, and family history. What's important for this conversation is there's no biologic determinant for racial disparities. What we see in the difference in mortality rates has nothing to do with genetics or biology. There's a number of researchers who have looked at the lived experiences of Black women. Arlene Geronimus, back in 1992, talked about how Black women literally are aging faster than white women because of the effect of racial and gender discrimination. You've heard a lot about sort of genetic testing and family history. Most providers, most doctors don't ask Black women about their family history. And so they don't know if they've got the BRCA gene mutation. And they don't order genetic testing for Black women unless they know, but they typically don't ask. So this is a conversation that doesn't take place between Black women and Latinas and their providers in general. And Tanae Lewis found that experiences of racial and gender discrimination literally changes what happens at the end of our DNA, the telomeres, that they fray, which triggers our metabolic and inflammatory responses, raising our risk for a number of cancers. The thing we know is that Black women and white women have the same cancer, the same diagnosis, and the same treatment, they will have the same outcomes. There's nothing about Black women that would cause them to die more often. But providers tend to blame comorbidities. They don't really understand the social determinants of health. And so it becomes the woman's problem to deal with rather than the provider taking the necessary steps to actually explore the possibility of ovarian cancer. And as you've heard, the test we have now to look for these markers, the CA-125, is not as sensitive in Black women. You've heard that test is going to miss perhaps 70% of cancers in Black women. Well, a lot of this has to do with how we came about to get to this point. On the next slide, what we typically hear is oh, it's, because of mistrust in the medical system, the lack of trust in research. There's some truth to that, and there's some absolute justification for that. More than J. Marion Sims, 150 years ago, experimented on enslaved women. Henrietta Lacks, who sells her Gila line, made a great contribution to therapeutics, but was never given credit. And then, of course, we all are familiar with Tuskegee. All of that seems, for many of us, like something that happened a long, long time ago. And many people have asked me, well, why does that matter? Medicine has changed, research has changed, science has changed. Well, just 2 years ago, Latinas in a mental institution in South Georgia were forcibly sterilized. So this is not history. This is still happening now. There are still reasons for Black and brown women not to trust the medical system. 2 years ago, the African American Cancer Epidemiology Study found that lack of trust in physicians prolonged symptom durations among Black women with ovarian cancer and delayed their diagnosis. So what we know is Black women don't have access to high quality care. They're not offered the highest quality of care. They're not offered genetic testing. And they're often dissuaded from seeking care for fear of mistreatment. Next slide. So do we need research? Absolutely. Much of the evidence we have on ovarian cancer and what we understand about it and therapeutics has not included Black women or women of color. And so, we say what becomes evidence depends on who's asking the questions and who they're asking, and frankly, who's funding it. But also, I lived in Trinidad for a number of years, and we had a saying there, it's not who you know, but who knows you. To get access to high quality care or get your research funded means somebody with some influence has to know you, has to advocate for you. The right people have to know you. And unfortunately, as you've heard, we haven't had a lot of success because the percentage of physicians and researchers of color hasn't changed in almost 40 years. Still, 5% of researchers, of physicians are Black and Hispanic. And when you look at NIH funding, those who are getting R01 grants, less than 2% are of color. Overall participation in cancer clinical trials is about 4%. And so there really isn't a disparity there. But because the Black and brown population is so much smaller, we're talking about 4% against a much smaller denominator. Enrollment of Black patients in ovarian cancer studies, according to the Journal of Ovarian Research, is declining. But the single reason Black women don't participate in clinical research is because they're not asked. Providers make all manner of assumptions about what Black patients will and will not do, and so they make the decision for them. Our clinical trial system certainly needs to be examined because it doesn't accommodate people of color or low-income people. The informed consent requirement alone is burdensome at best. But typically, trials are in academic medical centers or in suburban areas, so that requires time away from work, transportation, childcare, maybe lost wages. So, while clinical trials participation may not cost anything, they're certainly not free. So I would encourage you all, as I close, to really listen carefully to what Elena said, and certainly what Diane said. This doesn't have to be. We know what to do. We know we need more research. We know there are better tests out. We know providers can simply ask questions of their patients. And more importantly, as Elena said, they can listen to their patients when they complain the second time about symptoms consistent with ovarian cancer. They can take steps to make sure that Black women, women of color, all women can get their cancers diagnosed early when they're treatable so that they can live among their family, see grandchildren, enjoy their lives, and that we don't have to hear Diane's story over and over again. Thank you, Diane, for your courage. Thank you for this time.
Thank you, Linda, for shining that critical light on this disparities in ovarian cancer. treatment and outcomes. It's shocking and disappointing, and so much more needs to be done. And thanks, Dr. Ratner, for running through that description of the current state of treatment and diagnosis. It's a frustrating mishmash of treatments, I think, that patients around the country are receiving. But I think it's so helpful that you can enlighten us today on what we're seeing. And of course, Diane, your story is so important to spread. I'm so glad that you had the opportunity to address all these folks today. I wish that your story was unique. I wish it was the first time that I heard someone that spoke the way you have about your diagnosis and your treatment and your journey. But unfortunately, it's not. And let's all work together to try to make that story more and more uncommon as we move forward. I'm Chad Ramsey. I'm the Vice President of Policy at Ovarian Cancer Research Alliance, and we're the world's largest ovarian cancer patient advocacy organization. And we do advocacy, we do patient support programs, and we do our own research. We annually we do about $7 million in research grants, and it's so critical, we think, to continue that sort of work. Unfortunately, we're one of the largest nonprofit funders of research, and we wish there were a lot more groups doing the same things that we are. But we think it's critical, and we are making some progress here and there. So I wanted to talk about the next slide, a little bit about the current status of congressional funding for ovarian cancer research and awareness programs. And you can see this goes all the way back to '99. But really over the last 10 years, we've really only seen incremental increases in ovarian cancer research funding from Congress. And you'll see the big green line that you have there. That's NIH funding. That's from the NCI. And this funding is a little bit difficult to measure. Sometimes it includes basket trials, includes other types of research that are not specifically ovarian cancer related, but can be included as ovarian cancer research. So that's perhaps a little bit misleading to see that. But you are seeing just an incremental rise even since 2008, the last 10 or 12 years. I wish I had put on here a comparison of some other cancers, and you'll see that unfortunately there's a bit of a disparity in the way ovarian cancer research funding is administered. If you look at another cancer-specific, gender-specific cancer, prostate cancer, for instance, if you had the green line of NCI funding for prostate cancer, it would be more than double ovarian cancer, despite the fact that ovarian cancer is a much more deadly prognosis. There's also a prostate cancer program within the Department of Defense, just like there is an ovarian cancer program. That program is triple the size of the ovarian cancer research program for prostate cancer. Now, we want prostate cancer research. We think it's important, and there can be important outcomes for other cancer patients because that research is done. But we would like to see the support for ovarian cancer research and awareness programs brought up to that same level. It's critical, particularly as when we discussed 1 out of every 2 women who are diagnosed with ovarian cancer will end up passing away within 5 years. That is really disturbing. It's really disturbing that and we haven't seen much improvement over that on that statistic in years. And I think that with more awareness, more and a commitment to research, we might see some improvement. So we have a couple ideas, a couple pieces of legislation that we wanted to highlight moving forward. So next slide, please. And thankfully, Congresswoman DeLauro already mentioned Johanna's Law. Johanna's Law is the Gynecologic Cancer Awareness and Education Act. And it was first passed in 2006, signed into law in 2008. And it was named after Johanna Silver Gordon, who was a school teacher who was diagnosed too late, much like Diane. And Johanna's sister, Cheryl Silver, who was a force of nature, really brought this law into action, brought this law into reality by her constant advocacy. She thought that there wasn't enough being done to promote awareness of symptoms, and that there wasn't enough provider education that was being done to find ovarian cancer. And so when this law was passed, it put some money directly into the CDC program to really try to make awareness of ovarian cancer symptoms and other gynecologic cancer symptoms much more prevalent. We have seen some increases in this program over the years. The Inside Knowledge campaign that the CDC administers is really effective. But unfortunately, it's not being seen by everybody that needs to see it. And it doesn't matter how effective a campaign is, if it's not in front of enough eyeballs, it's not going to get the kind of impact that we would like for it to have. So we've worked with Congresswoman DeLauro to introduce a reauthorization of the program. And so I encourage everyone to look into and encourage your members of Congress to pass HR 4412. That reauthorization legislation will increase the funding for Johanna's Law, and also modernize it, have more of a focus on disparities, which, as Linda pointed out, is critical to look at, and also try to make sure that the program Inside Knowledge campaign gets in front of more people by allowing other types of organizations to help administer the materials and get it out in front of people. Unfortunately, the CDC's reputation is not considered the same by everybody around this country. And so we'd like to see that the different sources start administering these resources. And I think that could have a nice impact as well. The other thing I want to talk about here is the Congressional Directed Medical Research Programs, which is in the Department of Defense. This is the only dedicated ovarian cancer research program funded by the federal government. It is a critical program that began in the late 90s and was funded at about 10 million for a decade, and then at about 20 million for the next decade. And it's really been an effective program of moving that translational research forward. It invests in cutting edge, high risk, high reward research, which sort of differentiates it a bit from the NCI research that's done. And so that's critical in that program. Congresswoman DeLauro has been really out front in trying to increase the funding for that program. But this is another one where we find difficulty getting support on both the House and Senate to move that research number up. Currently, it's at 35 million per year, and that was after an increase just 2 years ago. And so we need Congress to finish their appropriations actions before the year expires, and try to get another increase for that program. It's absolutely critical. As we've talked about today, CA-125 is a 40-year-old diagnostic. It's a biomarker test, single biomarker that really just helps monitor your level of ovarian cancer. It's not really meant to detect, it's meant to monitor your progress. There are other biomarker tests that are much more precise that are moving forward, but we still don't have an effective screening tool. And so that's why this research is critical. Much of the research focuses on finding an earlier diagnostic. There's a real problem that we have, as Linda mentioned, the different diagnostics the guidelines that ACOG and NCCN have out there. They really support genetic testing for ovarian cancer patients. And yet only a third of ovarian cancer patients are receiving genetic testing after diagnosis. Now, why is that? Is that because where they're being diagnosed, they're not accustomed to sending them to genetic testing? Is it because the patient isn't asking for it? Is it because the provider needs education? It's probably a combination of all three of those. And so we think that there's probably ways to improve that. There's another piece of legislation out there that purports to allow Medicare to support genetic testing and other types of screening for patients that are family members or that are at higher risk. So for instance, if you are diagnosed with ovarian cancer, Medicare covers your genetic testing, but it wouldn't recover your family members. It wouldn't recover your daughter's testing. And so there's a piece of legislation out there called HR 4110 that would require Medicare to cover those types of testing for family members, and that could have a critical role in identifying ovarian cancer more quickly in earlier stages. There's other types of diagnostics out there as well. Along with OVA1, there's some new technology that's coming forward that we hope will eventually be FDA approved, such as the type of technology coming out of GRAIL and Thrive to identify multi-cancer early diagnostics in a single blood draw. So there are things moving forward. There are opportunities if we get enough support, if people call their members of Congress and urge them to support bills like HR 4412, and we can make some improvements. We just need to do a lot more. And hopefully this Ovarian Cancer Awareness Month will bring all the people together on this call and across the country together so that we can address some of these gaps.
Good afternoon, everyone. My name is Valerie Palmieri. I am the president and CEO of Aspira Women's Health. I'll be brief. I know we're close to the end here, but I do want to say a few words and then give the floor to Diane. I first want to state that as we're talking about technology, I've been CEO here since 2015. OVA1 was the first FDA-cleared ovarian cancer risk assessment, and it was FDA cleared in 2009. It is now 2021. And OVA1 is now in guidelines, but very few people are aware of it. So there's a long road for technology to actually get accessible to all. I also want to say a big thank you to Congress for allowing us to have this time to speak about the unacceptable state. Thank you to the clinicians and advocates who are in the battlefield daily. Think about it as a clinician. 1 in 2 women die of this cancer, and you have to face that each and every day. But most of all, I want to thank you, Diane, for your courage to come here on behalf of over 200,000 women that are living with ovarian cancer every day in the United States. 200,000, only 22,000 are diagnosed each year, but 200,000 are trying to thrive with ovarian cancer, and Congress should understand that. Moving on to the next slide, I want to just go into the brutal reality. And just to recap in summary, this is the only cancer that has greater than a 50% mortality rate. And there's technology in the market today that can detect it early, 98% of the time with ultrasound. 1 out of 2 women die. Today, the mortality rate for Black women is extremely high, much higher than Caucasian women. And it's due to lack of access, healthcare access, but also there is inherent differences in how CM125 measures certain histologic subtypes versus OVA1. Today, funding prostate cancer, 98% survival rate. Yet ovarian cancer has 36% less NIH funding. Today, every day, 60 women in the US are diagnosed and 38 women die every single day. Think about it, 60 women a day are diagnosed and 38 women die per day. And the cost, I hate to think about cost, but we spend $5.2 billion a year on ovarian cancer with 1 in 2 deaths. And an average ovarian cancer patient can cost the healthcare system about $1 million. Next slide. And just talk about access for all. This is a slide that we should all pause. We as a company have not forgotten those that do not have access to NCCN or comprehensive cancer centers. We have knocked on the doors of every single Medicaid state agency. Right now, I'm happy to report that with Medicare, we have coverage in 1 jurisdiction, but we need national coverage so that we don't have to actually get each and every MAC to get coverage for OVA1. On the Medicaid side, we need to have everyone have full access. Right now, we have 78% of the Medicaid lives covered. And you'll notice here that the states with the highest ovarian cancer incident rate, and they are not covering this diagnostic that is FDA cleared and in guidelines for risk assessment of ovarian cancer. Next slide. So my call to action is threefold. Number one is it greater than 60% of ovarian cancer is detected at late stage. It's all about early stage detection. Make OVA1, which is FDA cleared and ACOG endorsed, the standard of care for early stage risk detection for Caucasian and non-Caucasian women and late stage detection. The current standard of care may miss 37 to 67% of ovarian cancers in Black women. And it's not just Black women. We're seeing this in our studies in the Philippines and Israel. There are differences in care and risk in other races and ethnicities, and we need to understand that we are not a homogeneous population. As CEO, I fund large trials. I'm asking the government to help us fund large, diverse population trials to change the ACOG guidelines and remove CA125. And last, there's no national coverage for OVA1. We have to go after painstakingly each and every MAC. We need to obtain coverage regionally and at the state level, and this takes years. As I said, OVA1 was FDA cleared in 2009 until the technology became owned by the company itself in 2015. It's taken us 11 years from actually 6 years from 2015 to get into guidelines and to get payer coverage. We need national CMS coverage immediately. We need to turn the Medicaid map to green, and 14,000 women die each year. So Congress needs to act now to provide all women, especially minority women, access to the best-in-class ovarian cancer risk assessment. The policy actions needed, as we discussed, are Ovarian Cancer Awareness Month resolution, the Johannes Law, the funding for ovarian cancer within the NIH and the DoD, CMS coverage as soon as the FDA cleared so that we can get reimbursement once cleared. We need some consistent access for all Medicare beneficiaries, regardless of location, and we need to ensure that we have proper education and awareness. We are all in control as females, as mothers, as daughters, as aunts, as grandmothers to understand these symptoms because it is not silent. Just to close, and I'm going to introduce Diane. By enacting accelerated regulatory and reimbursement pathways, this Congress can be the change that is critically needed to optimize women's health for all in the US. And as I introduce Diane, I want to say some final words in terms of closing this briefing. I want her to discuss, in her words, from a patient perspective. The patient's voices need to be heard, not just heard, but need to be acted upon. Empty words are empty promises. And we need to ensure that as Diane's representing over 200,000 patients here today, that these promises, all the chats that I see here, that we act upon these chats and we put these words to action. So without further ado, I'd like to give the floor to Dr. Diane Powers. Diane?
Thank you, Val. Thank you to all the speakers today. You're just incredible. As I noted earlier, my life's journey is near an end. I urge you to push for a definitive end to the devastating prognosis that is the fate of most women with ovarian cancer. As Valerie just said, my call to action is on behalf of the 14,000 women who have died of late-stage ovarian cancer in the US this year, the 250,000 plus women who, like myself, have been living a diminished quality of life in this country due to their late-stage disease, and also the unknown thousands upon thousands of women that we love that may be at risk as well. You all and your constituents have the power to allocate funds and resources to influence policy. Please, I'm reiterating, but again, call to action, please improve education of women, of healthcare providers, of payers about the nature of this disease. Number two, please increase funding, as Chad so eloquently outlined, for more research in ovarian cancer, especially in diagnostics. Again, there is still no screening tool for ovarian cancer. So many women are under the false impression that they go to their gynecologist, they get a clear pap smear, they get a clear normal annual exam, and that means they're granted a clean bill of health. It's simply not true. They're at risk. Next slide, please. Number 3, public and private insurance, as Valerie mentioned, must cover the only multi-factor risk assessment of pelvic masses. We have the FDA cleared tools that are specifically designed to catch ovarian cancer early, stage 1 and 2. That's what needs to happen. It's time, it's 40 years past time to stop allowing providers to use the inadequate 40-year-old standard of care, the CA-125 test, which is not FDA cleared and completely inappropriate for all women of all races. 4th, we need to advance precision medicine with genetic testing. Our healthcare system is disjointed and broken. Women are falling through the cracks. I'm just one of thousands and thousands of them that have fallen through the cracks. We must advance precision medicine by offering all at-risk women genetic testing, not just after they've been diagnosed with ovarian cancer, but early in life. Knowledge is power, and women need that knowledge to make informed decisions about their gynecological health as they move through their lives. Please have our leadership drive this type of proactive rather than the standard reactive care for our women. Again, although my life's journey is nearing an end, I ask that all of you commit to making life-changing policies that promote a new and intense focus on prevention and early detection of ovarian cancer. Do it for the women who are no longer with us, and do it for the women who are with us now. Together, and all of you, we have the power, we have the resources to change the story, eradicate late-stage diagnoses, save lives, and preserve the quality of life for all women, regardless of their age, race, or socioeconomic status. Thank you so much for your time.
I want to thank our amazing speakers, and thank you, Diane. Your strength, your advocacy is inspiration for us all. It's hard to ignore your list of call to action, and we hope that you all will take it to heart and take action today. As one person commented, thank you, Diane. We are here and we have heard. We will pick up the beacon and carry it forward. Thank you once again for joining us today. We will send you the link to today's recording and look forward to working with you on this issue. This briefing is now concluded. Thank you so much.